Welcome to the Wellness Effect. Now, according to the South African Heart Foundation, around 40% of South Africans are affected by some form of cardiovascular disease. Dr. Andile Xana is a cardiologist based in Pretoria, and he's with me in studio today. Welcome, Doctor.
Thank you.
So, what are the different cardiovascular diseases?
Those are the diseases that are affecting the cardiovascular system. That would entail, it's mainly the internal aspect of our blood vessels, which we call the endothelium. So the endothelium is basically covering all of our bodies, coming from the legs, the intestines, the heart, the aorta, the brain. So it's the same system called the endothelium. It presents differently depending on the system that is involved. So in the brain, it will give you strokes. If you are unlucky to have the disease, in the heart, it will cause heart attacks. In the legs, it will cause what we call peripheral vascular disease, where the legs become painful, they change color, and if somebody has no access to good healthcare, they lead to amputations. It's the same disease of the endothelium, the internal aspect of the blood vessel.
And how many South Africans are affected by cardiovascular diseases?
They say about 40% of South Africans. Unfortunately, young ones get affected, mainly though it's a disease of growing up. It's a disease of degeneration, whereby from above the age of 40, the problems start. From 35, that's where the beginning starts. But if you look at old studies, we know that by the age of 21, half of the population already have endothelial disease.
Okay.
It might just be an abnormality, which won't necessarily progress to a disease.
And what are endothelial diseases?
Disease of the endothelium is where the endothelium, it wears, and then when it starts tearing, that's when we start getting sick. Where is as we grow, we lose the elasticity of our blood vessels.
Okay.
And then that leads to high blood pressure. The lifestyle doesn't help. A good lifestyle of exercise, avoidance of sugar, avoidance of salt, avoidance of bad fats, that helps you to delay the process. It might happen despite that. Also family history, smoking, all of those will all conspire together to increase the likelihood of the tear. The way, we don't know. It happens as we grow. It's part of nature. The tear, we tend to assist the tear. But genetics also do assist the tear.
And what can people do to kind of prevent the tear that you've mentioned?
It's maintaining a lean body weight. It's watching what we eat, avoidance of fatty foods, avoidance of what we call the bad fat, which is the animal fat, and avoidance of fast foods, unfortunately, and avoidance of excessive use of alcohol, avoidance of smoking, and the more exercise, the better.
You mentioned in your introduction the various diseases, cardiovascular diseases. Could you hone in on a few other ones?
It's heart attacks. It's the biggest killer on earth. In the developing countries, it tends to be on an upward trend. It plateaus, and then it tends to calm down. The calming down, we've seen it in the West European countries. It was going up in the 60s. In the developing countries, we were dealing with infectious diseases. And then there is a time where then the developing countries are called populations in transition. That is when now the infectious diseases are starting to calm down. The diseases with non-communicable diseases, including cardiovascular diseases, which is cancer, cardiovascular disease, they start going up. And in South Africa, we are a population in transition. That is when the cardiovascular conditions are starting to go up. The infectious diseases are generally controlled. The cardiovascular diseases that come from infections, they are also coming down. When one was training in the 2000s, we had lots of infectious cardiovascular diseases that was seen in children. It plateaus. We don't see it. The young ones that we get to train these days, they don't see the infectious cardiovascular disease that we saw. They don't know them because they are disappearing. The ones that we were told when we were training that they don't happen, especially in African people, cardiovascular disease like coronary artery disease, our professors used to tell us that. Fortunately, some are still alive. They told us that you won't see a heart attack in a black person. We I saw one much later in my life. I think it's about 5 years into practice. And then since then, it's been going up. So that is what the world has predicted, the epidemiologists of the world have predicted. It has nothing to do with race. It has everything to do with lifestyle.
And you, in your practice, what are the common cardiovascular diseases that you're seeing on a day-to-day basis?
I practice in an urban center where I see a mix of population, highly well-off, middle class, and lower middle class who happen to have medical aids because of the types of work they do. The most of the patients I see in the 40s and 50s, it's coronary artery disease. That's your angina, that's your heart attacks. Then there's another condition, heart failure. We see quite a lot of that, but it has not really changed over the years from the times when one would have been a student to these times now. What is going up is the coronary artery disease. That's your angina, that's your heart attacks. That is what half of the practice is about that. There would be diseases of heart rhythm, which also are going up as the diseases of the blood vessels are going up because they basically get intertwined. So those are going up as well. The diseases of the valves are not as much in the private sector as they are in public sector, because generally valvular diseases, most of them are diseases of being poor, of low socioeconomic class, that would have been acquired much earlier in the 90s, and then they present much later, now that the people are adults, and they are able to come into the private healthcare.
And the heart failure and the other cardiovascular disease that you mentioned, I think it's Andile. What causes that? Is that mainly lifestyle?
Heart failure, that doesn't really change with the times, with development. Generally, we associate it with genetics. It's common amongst African people where the muscle just fails on its own. And then sometimes we define the cause. Most of the time we don't. And then the other heart failure is when a coronary artery disease happens. There's blockage of a blood vessel. We don't open that vessel on time. The muscle that was supposed to receive blood, it dies off, and then it does not assist in the heart pump function. And then the ability of the heart to pump blood adequately goes down. And then that's when heart starts to fail in its function to deliver blood throughout the cardiovascular system. So that's when we say it's heart failure.
I see.
So the one that is going up is the one that is due to the blockages of the coronary arteries.
Yes.
The one that is static is the one that is due to the failure of the heart muscle.
Okay.
We associate that with either viral infections or with the genetics.
Okay.
But most of the time, especially in Africa, we don't know. In the Western countries, they try to find out. If your heart muscle is failing, they want to tell you why. And the patients demand that answer. In Africa, we generally don't. The burden is quite high. The development of our technology in terms of us having that ability all the time is less. And the number of people who can do these investigations is not much.
And for those who have blockages in their arteries, is that due to diet, cholesterol, maybe high blood pressure?
All of them intertwined with diet. There's a bit of genetics. There are people who are born with high cholesterol. It's common amongst the African people. It's common amongst the Indian people. And a lot of colored people who are of mixed race, they will be born with that. That's genetics. But then there's a lot of our lifestyle things that we enjoy the most, which is chisanyama, which is biltong, which is brevas. They help in the moment, but in the long term, zero.
Oh, Doc, you're touching on a very touchy subject for me. I love my braai. So how do we manage that? Is it a matter of moderation, not having too much of the braai? Because you can't tell a South African you can't have a braai. How do we manage it?
Everything in moderation, yes. And knowing, I think above the age of 35, it's quite important that we know our numbers. I mean, if my cholesterol is high, I have to balance issues of my enjoyment of my braai and my likelihood of living long.
And for those patients that come into your practice that have had cardiovascular event, what sort of preventative care, not preventative care, but care do you provide them such that they can, change their lifestyle and almost change their life?
Talking to the patient helps. If people were to stop smoking, a lot of us would have to look for work as cardiologists.
Wow.
But besides smoking, we need to walk more. They say that 30 minutes of walk per day will actually deny also us work. And also, if we can watch the diet that we eat, avoid getting hungry such that we stop and have chips. Just try to go home and have vegetables and less meat and more white meat and less red meat. It's recommended that we don't exceed a single serving of red meat per week. And then we need to watch our eggs. Eggs have got high protein, which is nice, but they've got a lot of cholesterol, which is not nice. So more than 4 eggs a week, that's a problem. It basically keeps us employed. And then if we exceed 2 beers a day, that keeps the cardiologist employed because that pushes up the blood pressure. If you take 1 beer a day, and then you keep the oncologist employed in the long term. So if you can avoid alcohol, you'll keep cardiologists, you'll give them less work, you'll give oncologists less work. So really it's things we do, a lot of things we do don't help us in the long term.
And what sort of advice would you give to an individual watching this who's been given this information about cardiovascular disease? Maybe they're noticing that their blood pressure is high. What can they do to prevent having a cardiovascular event?
There's no benefit in having salt in your body. It doesn't help. It helps in the tongue. I know that there are people who are told to have more salt or have Bovril because they have a problem of low blood pressure. There's no scientific evidence that helps anybody. We must be aware of our numbers. If the blood pressure is high, you go to your GP, it measures high today. They normally will give you a day to come back. And then probably if it's persistently high, you've done all the lifestyle things that you are advised to by a GP, then that's probably time to take your medication. And watch the numbers and also go to websites that are approved that will assist you. Then, so when you go to a GP, no matter how busy they are, say, just wait a moment, what is my target blood pressure? And then if you're not reaching those numbers, you ask them, what must we do to reach the numbers? We need to assist as patients. That is, we need to exercise. We need to watch our calories. We need to watch our BMI. And then there's no benefit of smoking. There's no benefit of salt. There's no benefit of sugar.
So 40% of South Africans are living with cardiovascular disease. That sounds like a pandemic. What do we need to do as a society to almost change habits and behaviors such that we don't pass on these diseases to the next generation coming up? 40% is almost close to half of the population. What can we do to almost shift the narrative around cardio, the silent killer, as it has been called?
In Europe, they've managed to delay the onset of cardiovascular diseases through the simple things that we're talking about here. The onset in the European countries is usually above the age of 50, definitely mainly above the age of 60. In Africa, it tends to happen in the 40s. The lifestyle we live, and especially a lot of people who are called middle class, they're people who come from a lower social class. So having access to a fridge filled with meat, it's like we don't think beyond the fact that I don't want to live the life that my father lived. And in the process, that's how we harm ourselves. That's what the Americans and the Swedes did, say, in the 1960s. And they've outgrown that. They cycle now to work. They walk more. And unfortunately, we've got less money to access. I'm sure you know the brands that sell the healthiest food. Tends to be more expensive. The meat that everybody can access, usually if they say malamohodo, it's got a lot of fat. So, and then if you want steak, say for example a fillet, it will be a bit more expensive. So we need to, as people that are poorer, we need to try and have more vegetables in our own gardens and try to grow our own food rather than buying it. try to cook it rather than buying it prepared. Because people who prepare, they put salt for taste. Because if I come to buy meat from you, you've put less salt. It's healthier, but for me, the taste isn't there. And when I go home, my kids will complain that don't buy there, buy there. And then what the prevention societies of the world recommend, there's something called primordial prevention. Okay. Primordial prevention is what we actually do to our kids. If in your family you teach your kids to drink more water, to eat semi-cooked vegetables, you put less salt on the food, because taste is learned. If your kids learn to eat food with less sugar, they learn to eat vegetables without salt. Then because salt is also it's a learned taste. Like beer, like wine, they are bitter, but people say they claim to enjoy them. Like whiskey, it's bitter, but people claim to enjoy it because they learn how to enjoy the taste. The natural taste is sweet, but people who are not introduced to that taste, that in primordial prevention, they don't learn to enjoy the taste.
That's good. So it really actually starts at home.
It's primordial. Primary one is to say that I must treat my blood pressure, I must treat my sugar, so I don't end up with a cardiologist. I remain with my GP. Now that's primary prevention. Secondary prevention now is when things have happened. You've had a stroke, how to make sure you don't have another one.
Correct.
Because the unfortunate part is that a lot of us get our wake-up call after the event. And then so most people are actually on the secondary prevention. Those are the patients we see, cardiologists see, neurologists see, and then oncologists see. Those are people who've actually had a shot. Now you're trying not to have a second one. But the best is primordial. The second best is primary.
Thank you, Dr. Andile. Remember to subscribe so you don't miss out on any future episodes. I'll see you next time on The Wellness Effect. BankMed, the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health.